A fundamental component of every eye examination is a determination of intraocular pressure. This assessment provides information on the ordinary function of the eye and assists in the detection of glaucoma. Once you understand the principles, the mechanics of checking intraocular pressure are straightforward. In this videotape, we will review how to measure intraocular pressure by Goldmann Applanation Tonometry. An individual's intraocular pressure may vary with time of day, posture, exertion, lid movement, medications, and diet. A single reading is only an estimate of the fluctuations that occur. From general population studies, it has been determined that approximately 95% of the population has an intraocular pressure of between 6 and 21 millimeters of mercury. There are a number of factors which have an effect on average intraocular pressure. These include race, refractive error, and age. Elevated intraocular pressure is not limited to the elderly. Glaucoma can occur at any age. Therefore, every patient who is able or willing to cooperate should have intraocular pressure checked regularly. The average intraocular pressure is about 15 millimeters of mercury. Hypotony refers to an intraocular pressure below 6 millimeters of mercury. Hypotony for prolonged periods of time is associated with deleterious effects on the eye. Intraocular pressures above 21 millimeters of mercury increase the suspicion for glaucoma. The higher the intraocular pressure, the greater the likelihood of developing damage to the eye. The optic nerve is most susceptible to this elevation in pressure. A patient with elevated intraocular pressure but no damage to the visual field or optic nerve is considered a glaucoma suspect or ocular hypertensive. If damage in the nerve or visual field is detected, a diagnosis of glaucoma is made. There are a variety of familiar ways to measure the pressure of an object, such as by palpation or by inserting a manometer or gauge. Since this cannot be done in a human eye, indirect methods of tonometry are used. Applanation tonometers measure the force necessary to flatten a corneal surface of constant size. We will concentrate on applanation tonometry with the Goldmann tonometer, since it is generally considered to be the standard to which others are compared. It is attached to the slit lamp biomicroscope and consists of an applanating replaceable tip containing a plastic biprism, attached by a rod to the housing piece inside, which contains a coil spring and series of levers that are used to adjust the force of the biprism against the cornea. Two beam-splitting prisms within the applanating unit optically convert the circular area of corneal contact into two semicircles. An important component of applanation tonometry is the tear film meniscus. The tear film meniscus is stained with fluorescein to allow visualization at the margin of contact between the cornea and biprism. As already noted, the circular area of contact is converted by the prisms into two semicircles called mires, seen here through the slit lamp. The force of touch, or applanation, is adjusted until the inner edges overlap. Intraocular pressure is then read directly from a scale on the tonometer housing. The marks on the scale are in 2 millimeters of mercury increments, although intraocular pressure can be estimated to the nearest 1 millimeter. The scale number is multiplied by 10, and this corresponds directly to the intraocular pressure in millimeters of mercury. In performing applanation tonometry, the patient should be seated comfortably at the slit lamp. The chin and forehead should be in their proper rests. A tight-fitting collar should be loosened. There may be difficulty positioning some patients. It helps in these settings to have the patient lean forward in the chair. The patient's eyes should be aligned with this marker on the slit lamp coil. After the slit lamp is turned on to its highest level of illumination, the cobalt blue filter is put into place, and the slit opened to its widest position to achieve the brightest light. The angle between the illumination device and the biomicroscope should be about 60 degrees to best illuminate the tip of the prism. Low magnification oculars are preferable. With many patients, it helps to preset the tonometer at 20 millimeters of mercury so that less adjustment will be necessary for the specific measurement. Prior to testing intraocular pressure, a topical anesthetic and fluorescein solution, such as Fluoresce, is applied to each eye, and the excess is wiped away. One may also apply fluorescein after administering a topical anesthetic by touching a moistened fluorescein-impregnated strip to the inferior conjunctival cul-de-sac. In order to avoid confusion, check the right eye first, then the left eye. The eye should fixate on a target away from the tonometer. It is important that patients not hold their breath. Rather, they should try to be as relaxed as possible. The lid should not touch the tonometer. If necessary, the examiner can manually keep the lids open, making sure to apply pressure to the bony orbit and not the globe. The slit lamp is moved to approach the cornea along the optical axis. The initial position should be slightly inferior to the visual axis, to slip under the eyelashes of the upper lid without touching them. The tonometer is then raised until the prism is centered on the cornea and gently brought forward with the joystick of the slit lamp. The slit lamp should be adjusted up or down to get 2 exact semicircles. Once the tip is properly aligned and positioned, the applanating force on the cornea is varied by turning the dial until the inner borders of the fluorescent mires barely touch. Intraocular pressure is then read from the scale on the tonometer housing. If the instrument is too far away from the cornea, the 2 semicircles cannot be made to overlap. If the instrument is too far forward, the semicircles cannot be separated. At the end point, the semicircles should be bright, symmetric, and sharply focused. If there is too much fluorescein, often from induced tearing, there will be a wide meniscus and an artificially high intraocular pressure reading. If there is too little fluorescein, which may result from evaporation of the stained tear layer during protracted measurement or in a dry eye, the meniscus will be thin and intraocular pressure will be falsely low. The patient should be told to blink several times and the measurement repeated. If pulsatile movement of the mires is noted, the final adjustment should be halfway between the 2 extremes. After each patient, the tonometer tip should be cleaned. Alcohol wipes have been shown to be effective, especially in inactivating most viruses. Make sure the tip is dry before testing the next patient in order to prevent corneal toxicity and maintain reliable readings. Other options for cleaning include soaking in bleach or 3% hydrogen peroxide for 5 to 10 minutes. Although Goldmann Applanation Tonometry is widely accepted and shown to be highly reliable, it is not without problems. Some of the difficulties are encountered in patients with surface changes on the cornea, including astigmatism, scars, corneal edema, and corneal thinning, or keratoconus. Astigmatism due to abnormalities in corneal curvature of greater than 3 diopters may influence the reading by producing an elliptical area of corneal contact. This can be minimized by adjusting the axis of the biprism. Convert the patient's refraction from plus to minus cylinder. Then set the red line on the prism holder to minus cylinder on the prism scale. Unlike some tonometers, Goldmann Applanation Tonometry cannot be performed over a soft or hard contact lens. Patients with marked corneal swelling from trauma or surgery may also be difficult to check. There are some ocular conditions where intraocular pressure may need to be checked with the globe rotated out of primary gaze. For example, in patients with thyroid eye disease, intraocular pressure may be higher in upgaze. After determining intraocular pressure in primary gaze, the patient's chin should be placed behind the chin rest while the forehead is positioned against the forehead rest. Intraocular pressure is then checked with the patient looking up. If nystagmus is present, it is important to have the patient fixate in the field of gaze that maximally diminishes the ocular movement. Finally, some of the difficulties encountered in the routine, uncomplicated patient may be due to improper calibration. Thus, it is important to periodically calibrate the tonometer every other month. This is done with a short rod of measured weight which is inserted into the housing of the tonometer. The rod has markings for calibration at 0, 2, and 6 grams, corresponding to 0, 20, and 60 millimeters of mercury. At each stop, the tonometer head should move only plus or minus 0.1 grams of the settings. The necessary equipment and instructions for this are included with the Applanation tonometer. If proper calibration cannot be achieved, the tonometer should be sent to a service center or the manufacturer. In summary, Goldmann Applanation Tonometry is an important part of a complete eye examination. Developing a routine of testing is essential. Proper positioning of the patient at the slit lamp, maximum brightness of the spot, and good technique will ensure accuracy and reliability for all patients.